So Bismillahirrahmanirrahim. In this video, we are generally going to talk about the alpha 1 receptor or organ system effects of sympathomimetic drugs. Now you know that receptors of alpha type that are acted upon by norepinephrine and epinephrine, they alpha type receptors, they are alpha 1 type and alpha 2 type. And in the alpha 1 type, they are further divided into alpha 1A, B and D. Now, when we talk about their agonists are norepinephrine and epinephrine, basically for alpha receptors, that is non-selective. But for alpha 1, selectively for alpha 1, we have phenylepinephrine. And I have explained to you how this one is for phenylepinephrine in the previous video. Now we will talk about the alpha 1 receptors. They are generally having GQ type of action, that is their stimulatory action. They are going to go for IP3 and DAG pathway, and due to which what will happen? They are going to have stimulatory effects. Now when we talk about their location, you know, this seesaw diagram helps you to remember their location very easily. So this is blood vessel. This is bladder and prostate. The one side we have dilator muscles of the eye, on the other side we have piloerector muscles of smooth muscles, and piloerector smooth muscles of the skin. Now what will the alpha 1 receptors do, or alpha 1 agonists do, which are going to mimic the action of alpha 1? They are going to vasoconstrict this blood vessel, they are going to dilate the muscles of the eye, they are going to constrict this piloerector muscle, and they are going to constrict the bladder and prostate. All of these are stimulatory effect. They are characterized by GQ type, and these all effects will be mimicked by this agonist, which is phenylephrine, which is a what type of agonist? That is a sympathomimetic. It mimics the action of alpha 1. So let's have a deeper look at it. So when it goes to the blood vessels, so it is present on the blood vessel as well. So when it goes to the blood vessel, what will it do? It will do venous, on the venous side as well as on the arteriolar side, there will be vasoconstriction. And as I told you, the alpha 1 selective agonist is phenylephrine. What will it do? It will do vasoconstriction. This vasoconstriction, what will it do? Whenever the vessel is constricted, it increases the resistance in the vessel. Why it increases the resistance? Because diameter has now decreased. This decreased diameter provides increased hindrance, so increased peripheral vascular resistance, also decreased venous capacitance. It means that the vessel diameter has decreased, so because of this diameter decrease, the resistance has increased. Also, the capacity of the blood vessel to fill the amount of blood that was previously being filled to it has now decreased. Two things: resistance has increased, and the capacity or the amount of blood it can adjust has decreased because of this thinning of the vessel or vasoconstriction. Now, because of increased peripheral vascular resistance, what will happen? Dose dependent rise in blood pressure will take place. Now, because we have constricted the vessel, there is increased resistance, there is increased blood pressure. This increased blood pressure will now activate the baroreceptor mechanism. This baroreceptor mechanism will now activate the vagus nerve. There will be increase in vagus tone and heart rate would be decreased. So this mechanism generally takes place. Blood pressure increased will go to baroreceptor, that will activate the vagus nerve, and hence it will decrease the heart rate. But the cardiac output, it will only increase. Why? Because whenever we are going to do with the peripheral vascular resistance, we are going to increase the resistance. That resistance will increase the blood pressure, and now the amount of blood that is going to heart has increased. So increased venous return. Because of increased venous return, the stroke volume will be increased and cardiac output will hence be increased. This is direct effect. But the blood pressure increase was causing baroreceptor reflex because of vagus nerve. So two of these things occur simultaneously. Now, basically on the heart, what alpha 1 has, generally it has inotropic effect, that it increases the force of heart contraction. Why it increases the force? Because there is now increased amount of blood in the heart. But because of increased blood pressure, the baroreceptor reflex is enhanced or it comes into action, so there is decreased heart rate. Majorly it was inotropic, increased force, but another reflex is generated, reflex is activated, so there is a counter effect produced. Now we can block the baroreceptor reflex. There are two things that can block it. Either you can block it via drug, or either you can have it blocked via disease. So the drug which can do the blockage is pre-treatment by this ganglion blocker, that is trimethophan. So this trimethophan, what it is going to do, this is going to block this baroreceptor reflex. When this baroreceptor reflex will be blocked, what will happen? The blood pressure will now increase. Phenylephrine will have increased pressure effect by 10 folds, and bradycardia or decreased heart rate will not be observed. Rather, we will have increased blood pressure, increased heart rate, the positive inotropic effect. But in another thing, that is diabetic autonomic neuropathy, in which what happens that the adrenergic nerve endings, they are blocked, they are destroyed. What happens? Tachycardia is observed, increased blood pressure is observed, increased heart rate is observed. Why is this observed? Because blood pressure and heart rate were increased, there was the normal function. But now to counteract the blood pressure, no baroreceptor reflex occurs. That is why you have both increase in blood pressure and increase in heart rate. But this can have therapeutic uses as well. In alpha 1, in diabetic neuropathy, we can give alpha 1 agonist, that is midodrine, and this midodrine helps in the treatment of orthostatic hypotension. Hypotension is a type of disease in which whenever you stand up, for example, you are in a sitting position, and whenever you stand up, what happens that you start to feel dizzy and you fall down. Why? Because there is hypotension, there is decreased blood pressure is occurring. So to treat this type of orthostatic hypotension in diabetic autonomic neuropathy patients, what do you give? You give midodrine, because there is now no counteracting mechanism, no baroreceptor mechanism to counteract the action of this alpha 1 agonist. So this is how it works. You can block it by trimethophan, or you can treat orthostatic hypotension in diabetic patients by the means of midodrine. I hope you understood this one. Now I told you that in this alpha type of receptor, we can have either norepinephrine and epinephrine, which are non-selective type of alpha agonist. So these non-selective type of alpha agonist, what they will do? Alpha agonists, they are always going to be producing stimulatory effect. So whenever they go to skin vessels, the splanchnic vessels, they are going to activate alpha receptor, they are going to do vasoconstriction. Same goes for nasal mucosa, alpha receptor activated, vasoconstriction, decongestant action of the nasal epinephrine, norepinephrine drops. But in skeletal muscles, the type of effect that the epinephrine and norepinephrine produces depends on whether it is having alpha receptors or beta receptor. If it is having alpha receptor, there will be vasoconstriction. If it is having beta receptors, it can be vasodilation. But in alpha, it can either be alpha 1 or alpha 2. So the type of thing that takes place in skeletal muscle, it is dose dependent. But you can remember, skin vessels, the nasal mucosa, the splanchnic vessels, there will always be vasoconstriction by the epinephrine and norepinephrine. After that, now we come to alpha 2, and by the mnemonic, this one mnemonic, the KISS mnemonic, you know that alpha 2 receptor, they are inhibitory in their function, and for their location, I told you can resemble it by a tree, that they are present generally in blood vessels. The leaf like structure for this tree is pancreas, the roots are nerve terminals, the fruit is either platelets or the adipocytes. So it is present in all these things. Now for alpha 2 selective agonist, we have clonidine. And the type of alpha 2 is further divided into alpha 2A, 2B and 2C. You need to remember this. They were A, B and D. This is A, B and C. Now when we come to alpha 2 receptors, they have systemic effects. For example, if you look at this blood vessel and if you give alpha 2 agonist, that is clonidine, what will happen? You have given that patient systemically. So what will happen is that there will be vasodilation produced, because alpha 2 is inhibitory in action. So it will do vasodilation. Inhibition of sympathetic tone, that actually means vasodilation, therefore decrease in blood pressure by systemic effect of alpha 2 receptors. That is why alpha 2 agonists like clonidine, they can be used in the treatment of hypertension, that is increased blood pressure treatment. Why they are used? Because they act like sympatholytics. What are sympatholytics? That reverse the action of sympathomimetics. So alpha 1 has the alpha 1 is producing vasoconstriction. Alpha 2 systemically it is doing vasodilation. So it is counter effecting the action of alpha 1. So it can be given as a sympatholytic, breaking down the action of alpha 1. So this is very important. But now they're saying that if you give the alpha 2 agonist via intravenously, you inject via vein, or you give via oral route in high doses, what will it do? It will do vasoconstriction. So systemic effects are sympatholytic effects. You can remember SS. Systemic effects are sympatholytic effects in alpha 2 1. Systemic effects are sympatholytic in alpha 2 receptor. But for intravenous route, for oral route with high doses, you get vasoconstriction in its blood vessels. So this is type of, you can say, a type of different thing that is found in alpha 2 receptors. Now, autonomic failure. For example, there is neural degeneration of postganglionic noradrenergic fibers. What do I mean by this? You see these nerve terminal. These nerve terminal are postganglionic type, and they are noradrenergic because the type of neurotransmitter releases norepinephrine. So postganglionic nerve terminals of the noradrenergic type, what will it do if they are being degraded? What will happen in such a situation? That clonidine will now not have its effect. Clonidine was supposed to be given systemically, and it was supposed to be acting like a sympatholytic, and it was supposed to decrease the blood pressure. It was supposed to do vasodilation. But due to this neural degeneration, what will happen now? There is no counter-effecting mechanism. The peripheral vasoconstriction will now be intact because alpha 2 cannot act on this type of blood vessel. Why it cannot act? Because it is not reaching the type of synapse. It is not reaching the synapse because the synapse has been broken down. There is neural degeneration of the synapse. So when there is neural degeneration, what will happen? That there is nothing to counter effect this action on the blood vessels. The blood vessels will remain vasoconstricted, and hence there will be increased in blood pressure observed despite giving your clonidine, that is a vasodilator, that is a hypertension treater. So clonidine will not exert its effect on the type of people that are having neural degeneration of their postganglionic nerve terminals. So I hope you understood each and everything that I explained via this action. These were the general effects of alpha 1 and alpha 2 receptors agonist and the alpha non-selective agonist. Till then, we'll meet in the next video. Till then, please like, share and subscribe to my channel, and keep on watching the videos and give good comments in the comments below so that I'm triggered to make more videos. Bye bye. Allah Hafiz.